I think Nate probably would. They have Nate.
I don't know, some of them, he may run us through insurance and stuff
Yeah.
like that too, or some of them, but.
I don't know what Nate's last name is.
You are?
Should do anything to spend time with Nate, because they all.
Yeah, like those
They all
with,
know.
yeah, same with Sam.
Yeah, they all.
I've known Samuel since he was like, he's big, so
Yeah.
I call him Samuel. Everybody else, I don't know, Sam. It's like, we're not, you know.
They all think it's Lizzie Cinder said last year, they're getting ready for something. It was sectional, I think. And Hannah Harris was like having issues with her arm or whatever. And Jason said, well, go back there and have Nate roll you out. And Lizzie goes, oh, I'll let Nate roll me out. And Jason's like, Lizzie brace.
Yeah, you don't want your best to say, right?
Yeah. So if you've never been down here, there are two back rooms. That door, there's one there. It's a very comfortable in service. Of course, we're always going to be respectful to Amy, but if you need to get up and move, please do so, especially if you're tired from working. Sometimes going from work start. You can look around. They'll probably see me pop in and out too. This is being recorded, but your pictures are not. So just your voices and the screen. And then we'll have this of your conversations through the slides. So just be mindful of that because we're going to keep the recording. So if you're talking about any patient cases, anything that you've seen, feel free to bring that up because conversations are great. Just do it in a way that is compliant because we are recording. With that, I'm gonna turn it over to Amy.
Thank you.
I don't know why Amy is so nice to me, but she sure is. This was, by the way, one of the biggest requests from your education needs assessment survey that we sent. So this was requested for you guys. So.
Okay. All right. I think everyone knows, so I don't think anybody needs to. I mean, to tell you who I am. So.
We're gonna start with introductions.
Yes. She's not listening, just like she doesn't listen to class.
We're popping.
I was giving her a hard time. But you guys, so tell me, how often are you getting this ordered?
Once a month, maybe.
Okay, yeah. Once a
Maybe.
month or so, okay.
Not very often.
Yeah, that's what, whenever I was working, we didn't get it ordered very often at all either. So, yeah, it's a good thing to refresh on. Common indications that you guys could probably tell me what you've seen in the past. Dimples is usually the most common thing. Tucked hair or something, or discoloration on the back and the spine, area. But you could have hemangiomas. You could have a little appendage, on the back, which those more severe ones are very high risk for some sort of dysrhythmism in the spine. So those are a little more skin discoloration. Probably tethered cord is most of the time what they're, wondering, there's something, a dimple or something like that. Is there a sinus tract to the spinal cord? And is there a tethered cord? So that's usually what we're going on. I'm sure, there could be some trauma from delivery and cause maybe hemorrhage and that come down into the spine. And a hemorrhage, I'm sure you guys know, acute hemorrhage, it's going to be echogenic. So it's going to be seen in that subarachnoid space, that anechoic space is going to be hemorrhagic. It's going to look echogenic down in there. So that's something that maybe you might run into post-surgical. I don't know. Taylor told me that the NICU here is pretty good. We're keeping a lot of babies here. So, I guess you never know if we do have some surgeries. I don't know if that's something that they might send out if there was a surgery for a spine. They probably send out, but Post-surgical, you could look for, and lumbar punctures, probably not doing rooming lumbar punctures on babies. So, but, for example, maybe they tried a lumbar puncture and they tried, and now we're taking a look to see, oh, is there a hemorrhage in there now? What kind of damage did they do when they tried to do some, lumbar puncture? Oh yeah, I forgot. Sorry, I just made this butt. I always do that. You can ask these guys. Oh, I forget. I put that in there. The discoloration, tuft of hair, little appendage, and hemangioma. Those are some of the more high risk things for some sort of spinal dysgraphism. So external indications, some sort of mass, a discoloration, a skin tag, hemangioma, atypical sacral dimple is like we were just talking about, most common reason. And usually if they're not at least 2.5 centimeters or more away from the anus, they don't usually send them for ultrasound. And then if they're larger than 5 millimeters, all those things are associated with something maybe more. So another thing with the dimple, if if it's in the crack and you open it up and try to look at, if you can't see the end of the dimple, that's more worrisome too, obviously. And then of course, if the dimple has a tract to the spine or something like that, that would be really make you nervous about getting an infection into the spine. So worry about other indications. These are just some things to remember. Probably if you're like me, I'm like, oh, I heard about that. I remember reading about that, and I'm like, I don't remember. So I brought some of these up. Caudal regression syndrome. That one is associated with mom that has diabetes, uncontrolled diabetes, like in the first trimester, that can cause caudal regression syndrome. So it's a wide array of things, but some of the more common things that are associated with caudal regression syndrome is sacral agenesis, anorectal malformations are associated. Caudal regression also has that. It's so funny, even when you think about things, it shows up on your phone. I don't know, maybe I said this out loud, I don't really know, but on my phone, I was scrolling through and there was a picture and some sort of thing, who knows if it's even real, but about sirenomelia with like the mermaid
I did.
syndrome.
I saw that
Did you
too.
see that too?
Yes, I did.
We're on the same thing.
Same things.
But yeah, that was great. So that's a subsection of the caudal regression syndrome. So where the legs are fused in some sort of way, maybe one bone or two bones, the skin is fused, something like that. But anyway, Currarino triad also has anorectal malformation, sacral mass, and a partial sacral agenesis. Always the S1 is intact with that one. I had never heard that one before. I looked up the AIUM guidelines for the neonatal spine, and this was one of the things that they had added. So I looked up, the most recent one was 2021. The one before that was 2016, and they had added that. I'd never heard of it before, so I looked it up, and that's what it is. So and then Bacterial, that stands for all of those things: vertebral, spinal things, anorectal, cardiac, tracheoesophageal things, all of those together for the Bacterial. And the OEIS, it's funny, we talked about that in class the other day, the OEIS, phallicil, cloacal exstrophy, and perforate anus and spinal defects are all in this. And then we had one of the students say, oh, we just scanned that the other day. I was like, it's kind of fun whenever you're talking about some weird thing and they're like, I saw that. So that's kind of fun. Always have trouble pronouncing this one, diastematomylia, which is like separation or like a duplication of the spinal cord. So it looks like two spinal cords. Hydromelia and syringomelia, those are kind of the same. Syrinx, you guys heard of a syrinx? So when you're scanning the spinal cord and the echogenic line down the middle of the spinal cord, so if fluid gets in that's a syrinx. I've not heard about it before till I was helping with MRI, and I'm like, this MRI looks weird. And so they're like, oh, that's a syrinx. I didn't have any idea about that beforehand. So, but those two terms, one of them, it's particularly their locations, but they're both fluid within the midline of the spinal cord. Okay, trauma, tumors, sacrococcygeal teratomas can grow outside, but they could also grow inside intrapelvic. So that's sometimes it's hard to maybe see. Just a review of the anatomy. The conus, of course, comes down to cone. That central canal is what I was talking about. The hydromelia or syrinx is going to be fluid in that central canal that you might see. And then the conus, it will come and kind of give way to that phylum terminale, which is just like a band off of the conus. It's actually pia matter, but it goes all the way to the coccyx. It kind of anchors the coccyx and the spinal cord together. So the cauda equina, the nerve roots down there, you should see nerve roots all the way. And then the cauda equina is just a little bit more nerve roots. The dura sac, that dura lining, the spinal canal dura lining is also called the theca sac or the thecal sac. And that usually ends at S2. That's one of the things that you can use to count, one of your counting methods, because usually, everything is, sometimes we can't always go with usually, but usually it ends at S2. So the thecal sac ends at S2. That's something you can use to count. Also, you'll notice the lumbar is straight across parallel, and then the sacrum is angled. So that curvature, the lumbosacral curvature, is another thing that you can use for counting. These spinous processes, coccyx, especially in newborns, those aren't ossified yet. If they do become ossified, they're going to be more round than the sacral elements. Sacral elements are usually flat on the top. The subarachnoid space. So the dura is what this lining here, the dura and the arachnoid matter are kind of together. There are two layers there. So this is a subarachnoid space where the CSF fluid is and the nerve roots are. I love this picture. You guys probably think I'm pretty nerdy, but the CT, I think this one is 39-week CT, but you can see how the posterior elements open to have a little bit of space there to get through. And then all the way to, I think that one was like 8 months old, and then it's finally closed up. So, and that one was like 8 weeks, I think. It's still a little bit of space that where maybe we could get some sound waves through. But otherwise, if you're doing early, of course, probably, do you guys have like a cutoff? Do spines after 6 months or 6 months? Yeah, I mean,
That's a big thing we do.
If we've cut off, I thought we cut off spines.
I don't
Maybe
know.
not. Okay. I think we have this conversation every time we like.
And then we
see what
know,
we're
we
like-
don't know what to do.
right.
And then we have our hips down because that took a little bit of like
Yeah.
sorting out.
But whenever, if it's later, you can maybe come over parasagittal and kind of come in like this. Of course, you're gonna have that shadow from that lamina, but let's look at that's fine. But that usually closes up, that in the back, it usually closes up 4 to 6 months or so like that. So this is just another nice image. We've got a nice transverse image, and you can see that dura lining is here, subarachnoid space with the fluid in there. The spinal cord, that central canal, still echogenic. And then we've got some nerve roots coming off around it. Conus, cauda equina, phylum. Can't see that really great in that image, so I'll try to find another one. Techniques. I mean, you guys have probably done it before, but prone is good. You could scan them, decubitus, but you have to think that spinal cord and the cauda equina are dependent. So don't mistake like a mass if the baby's laying DQ, because those cardiac equine are going to fall dependently. Okay, so you're going to have to think about that if you're doing something in the DQ. But if the baby is a little bit upright, or maybe laying on mom or something like that, you use the gravity to bring that spinal fluid down. It kind of helps fill up that fecal sac, and you kind of see it a little bit better. Prone with the knees flexed, sometimes that makes the babies a little happier. Laying against mom, done that before too. So all those are, do any of those. So the AIUM and the ACR says long and transverse images. And so you need to do at least from lower thoracic all the way through the coccyx. They, in the ACR, you guys ACR, you do the ACR accreditation?
Someday.
Someday, I don't know. Yes, it's a lot of work. But anyway, it said that in 2026, every image needs to have the vertebral level on the image. Every transverse image, which the AIUM says this too, every transverse image needs to have right and left labeled. And then their transverse, they would like you to label what level you're at on the transverse ones as well. So that's something that I found, back when I wasn't always doing that. So since I found that. What kind of things do you need to have? Sagittal images, midline, older babies, we just talked about that. You can scan off midline. Scan from the lower thoracic through the coccyx. Evaluate any mass or dimple. And if there was a dimple, always you can do long or trans. You can use a step-off pad, or you can use a big clump of gel or something like that. And then also get the spine in the image so that you can let them know, oh, it's down here by the coccyx, or oh, that dimple is up there by L4, L5, or whatever. So that's always a good thing to do, is to kind of show them where in relation to the spine is that dimple. So if the dimple is down by the coccyx, and you can find a little tract from the dimple to the coccyx, that's usually a pseudo tract. Now, a dermal sinus tract, that dermal sinus tract is going to be up higher, and it's going to connect with the actual spinal canal. So document where the conus is, where it terminates. Nerve roots, you can do Sine clips, transverse or long, showing how the cardiac respiration and the cardiac pulsations and the respirations kind of move those nerve roots. So you can do that with M mode also. I think either one. It didn't say one or versus the other was better or not, just as long as you're documenting mobility. Because if you have a tethered cord, it's going to be tight and they're not going to move as much. So document termination of the fecal sac. Like I said, that should be S2. And document the phylum terminale and measure the thickness of it. So that terminale, the phylum, it's usually it's echogenic, but it can get fatty. So it can get more echogenic if it's a fatty, or if it gets thick, sometimes that can get more echogenic than what it normally is. So I think I've got something just there. Counting method. So the AIUM suggests that the lumbosacral curvature, or the angle, is the most reproducible way to count. So I got an example of that here in just a minute. But the lumbar is usually horizontal. Then you have the sacral. So L5, find that and count up. The first coccyx segment, that varies in ossification, but like I said, if it is ossified, it should be more round. Then the sacral elements should be flat, so you could count from there. You can use the F2, the fecal sac, to count up from. The last rib, T12, find the T12, go over. You can use that to count down from. However, they say that this is less reliable because you can have an abnormal amount of ribs. But as we all know, you can have an abnormal amount of lumbars too. So, and then sometimes you can just double check yourself. Use two of the ways and see if that, see if they both match it. Of course, if they're really off and you can't figure it out, you could always do a radial wave marker and find out, do an x-ray. So, here's a good example of the L5S1. You can get that angle there, L5S1 count. About S5, and then that coccyx is a little more round on that one. So, but localization is very crucial for the conus because normal is at or above L2, L3 disc space. Okay, so we're worried about where it is. If it's lower than that L3, if it's down L4, L5, then maybe we have some sort of issue with the posterior elements. Maybe there's spinal, spine bifida or something like that is what we need to be looking at. Now, think about this. I know we have the NICU here, so we may happen to have a preterm infant. So sometimes early babies can have the conus terminate at mid-body L3. And maybe that might be normal for them, but they would probably suggest to do another scan when the baby reaches 40 weeks, somewhere between 40 weeks and 4 months, to double check to see if it kind of rose. Okay. So that's something that's possible. This another example of counting with that curvature. You guys know that I love pictures, so this is just more pictures. But this one particularly, you know, that angulation there on that lumbar is not as noticeable as that one, right? So that's one thing maybe if you are having trouble, maybe if they're very rounded, that's going to make that flatten out a little bit more. That's going to get rid of your curvature there. So you may do some flexion or extension or less of rounding of the back to see if you can, you know, really see that angulation there to count. If you guys have anything to say, just start it out.
I have a question. For when you guys are doing your exams, is this going under?
Yes.
So yeah, I noticed on the ordering guide, there's no age. So are you getting like random 10-year-olds put on your schedule?
One time we had like a class try to get scheduled. It was feeling like it was this year. We
So
called.
maybe we need to have that for you.
Right. I do remember we had like I was like a 2 or 3 year old, and we wanted to make sure it wasn't like a lumbar bump, and it wasn't. They were like, no, we want like, what was it, like scoliosis or something? It was something
Maybe.
like that.
Yeah.
And we were like, no. So yeah, I think that was kind of reason.
So 6 months, is that the?
I would say 6. I would say you probably could do a little older, I guess.
I
The
worry a lot about
radiologist, I would say approval, you know.
The biggest thing is movement.
Yes, yeah.
I worry about like the weight.
Yeah.
As well as the ossification, but mostly.
Right. Yes.
Like that would be probably my biggest.
Yeah, more pictures because I love pictures. Conus kind of goes into that phylum. Not great image for that, but good image for the conus. You can see the dura. You can see the nerve roots on that bottom one coming off, which is nice. You can also appreciate how the nerve roots and the cord is more dependent. This one is another nice example. That phylum is going to be, I don't know if you can tell right through there. So dependently layers. So make sure you keep a mind on that if you're scanning them. Fecal sac again terminates at S2. Should. Phylum, this is an example of measuring the phylum. What I could read about is that the measurement should be done about the level of L5S1. And that the phylum should not measure over 2 millimeters, so it should be less than 2 millimeters. However, some recent studies have been lowering that cutoff to 1.1 millimeters for normal. Yeah, so it's a good
No, we've never been told to measure that.
measure. Yeah, okay. You can't, if they don't have you do that, you just keep a mental note about, if it looks thick, might take a measurement. Tethered cord's gonna have a thicker phylum. So, that's something. And also watching the phylum move as well is, important. The nerve roots and the phylum and the cord, watching all that move. So anyway, those are some numbers for the phylum. And then you can it's echogenic, right? But you can get a fatty phylum, you can get lipomas in the phylum, you can get cysts in the phylum. So that's something that might, keep in mind on. That's a normal echogenic phylum. If it gets brighter than that, then they have something going on. This is just an example of the movement. I wonder, will this work? I think it will. Little clicky thing, yeah. Should. That's an example of the end mode. Of course, I couldn't find actual live scans, but then I did. And so we'll see if these work. But first, dependently, the cord should be either low or central location. Okay. If you have a tethered cord or a tight phylum, of course it's going to be up. Okay, so it's going to be more dorsal. And I have a picture of that too. Nerve roots oscillate with the normal cardiac, respiratory, end mode, sine clips. Either one is good. And you can do that in the long or the transverse, but it needs to document the conus, the cord, the phylum, and the nerve roots. So probably long axis, but you could do trans as well. Another thing I found out was that dehydration can lead to less mobility. So that's something that might, it said that preterm infants or brand new babies may be a little dehydrated. So that might be something that's worth noting. Oh, yeah, that might. Oh, do I have like 3 of them up there, baby?
Does it have sound?
I don't think so. I think it's just a quick little clip. It just shows, we haven't done it in a long time or what. That's great. See, count 2, and there's that angular, so that's 5, 4, 3, 2. Looks like that conus is about 1 to 2. And then you can see those hip moving. That was all the fun there was. So sorry, it wasn't more fun. I don't remember. I think this might be a transfer. We'll find out. Get there. Yes. Of course, we're looking at those bony elements too. And that hypoechoic at the very top is that spinous process. And then, of course, we're looking at that, making sure that doesn't come open. That's just a step down through all the way to the coccyx there, hypoechoic. That was awesome.
This is where I get my education. There you go.
Yeah, and then notes. Where's my notes? This website. I know you're gonna get this PowerPoint, right?
Oh, yeah.
Mouse. Maybe. Anyway, this website was pretty cool. Oh my gosh.
It's a little junky. Try Control C. That works better.
This was a nice website that I, seen a couple of these, different things on here and that's where these, videos came from. So axial normal, the decubitus. And you see how the cauda equina is over here to the side. So don't mistake that for a mass with the baby is laying on the side. So these were really nice little images. Coccyx, you can see how that S5 is flat on the top. And then there were some of these images I took to use, and you see how that one's round. So that's coccyx. And then it has some abnormal stuff in here too. So there's a thick phylum. I guess those ones we were talking about. Oh. Do you notice that central canal? There's a little bit of fluid in there. So that's the hydromelia or syrinx. When you get down right there, you see it's very echogenic and thick, that phylum. Much thicker than the one we just saw, so. Okay, anyway, but yeah, I really recommend this little. But I tried to put it in there for you guys though. Transverse, of course, we're gonna look at those neural arches, the lamina, make sure that they're coming to a point, and making sure that they're not splayed open for any spina bifida. These were like from superior to inferior. You have the spinal cord, the nerve roots coming off around the sides, the conus, the cauda equina. The phylum is going to be in the middle of that. This is an example of a dimple with a standoff pad or a big lump of gel. You know, identify where it is, area of the coccyx. And then this one, you can see L5 and there is a sinus tract. So it's up higher, that dimple, and it has a tract right down to the thecal sac. So that's more of a true dermal sinus. That's an example of there's some fluid in that cord, but sometimes in the first few weeks when the baby's born, you can have some dilatation and then it goes away. This is another normal variant, a ventriculus terminalis, kind of like a fifth ventricle. It's just a remnant, and then this usually resolves too. It's going to be where the phylum and the conus are come together. And it should be less than 2 centimeters. So that's something that you might see. Here's a phylum can have a cyst in there, then walt cyst. That's an example of that. Cauda equina pseudomass, just when they clump together when babies decute. This is an example of that pseudosinus tract where you have a dimple and the tract goes to the coccyx. Of course, there's no spinal canal down there that's to the coccyx, so it's just a pseudosinus tract. Tethered cord, which is something that we're going probably most of the time we're looking for. So counting is really important, and finding out where the conus is. This is below L5, and here the phylum is very thick. And this one, it should end at or above L2, L3. So it's lower, also lower than where it should be as well. So tethered cord might mean just a tight phylum. It might mean there's a lipoma in the spinal canal, somewhere in the spinal canal. Apparently that's a kind of a more common thing than I realized. A sinus, an actual dermal tract, sinus tract may pull on that phylum and may cause it to pour down, be tight, thick, and of course spina bifida. And of course, a tethered cord is going to restrict the movements of the nerves, which is why we do those. So pathologies, these are just some of the common pathologies that were in the AIUM thing that I printed off. So I thought maybe we just, run through a couple of these. Hemangiomas are associated with lumbar, a lower body hemangioma, urogenital, bone deformities, anorectal, renal. So a lot of these syndromes and things that have to do with spinal dysrhythmism have also renal issues as well. So that may be something that you might consider. Arachnoid cyst, which is what is on that top image up there, arachnoid cyst, syringohydromelia. Here they put those two words together, syrinx, they put those together. That can be associated with a tethered cord, neoplasm trauma. So a couple of slides are closed spinal defects without a mass on the back. Dermal sinus, we talked about that. And the thing to be concerned with on these, does it connect to the spinal cord or column, that fecal sac, and, higher chance of having infection if it does. So, lipomas. Lipomas can happen in the phylum, like that one up there, very echogenic, focal echogenic spot. Lipoma in the phylum, very thick. That may cause a low-lying cord also. Intradural lipoma, just anywhere in that dural cavity could have a lipoma. Diastematomyelia, say that again. I always tell my students, you guys say it 3 times fast. So just a splitting of the cord. And something to think about is that ghosting artifact, if you remember that. Just make sure you're not getting a ghosting artifact. So maybe if you see it, scan through and change your angle just to make sure. This one is, I'm so glad that I found this that had these colors on it, because I'm like, what the heck is happening in here, right? But this, so a lipoma with a dural defect, you can have any one of these 3, lipomyelomeningocele, lipomyelocele. So it's a lipoma. Usually these have a mass on the back, and it's a lipoma. Okay, it's this fatty tissue mass, but it's connected to the cord. And the term for it is wherever the cord and the lipoma meet. Does it meet outside of the vertebral column? Does it meet inside of the spinal canal? Is the term that goes with it. So the green is the lipoma, and then we've got the spinal canal there. So something to think about. These are associated with a hemangioma and hair tuft on the outside. Meningocele, myelocystocele. There's 2 types of myelocystocele. Is just the cystic herniation. There's a dilated central canal. You can probably see that on that bottom one, that the central canal is dilated, probably more than we've seen it on. So that's dilated, plus a meningocele. So a terminal is just that term when it's lumbar, in the lumbar. So myelocystocele could happen anywhere in the spine. The ones that are in the lumbar can be associated with the OEIS. So other things, maybe issues with the anus, cloacal extrophy, all of those things together. So, and the meningocele is just that dural sac is herniated. That's an example of that. I think that one's a transverse view. The dural sac and cerebrospinal fluid is herniated through a defect. So there are no neural elements in that one. This was just terminal myelocystocele. There's fluid in that spinal canal. So there's meningocele, and then also that those neural elements come out as well through that defect. And then open, I didn't even find a good image for open because we're not scanning those. Maybe we might scan up above the defect, maybe below the defect, but we're not. Those are obvious. we're not gonna be putting gel on those, right? So, that was in Europe. So, yeah, the meningeal and myelo meningeal with the neural tissue out. I think that's it. And then, most of the thing, where I found most of these things, I put on here too. That way, if you guys wanted to look through anything, you could do so. Oh, thanks. Hopefully that helped. Oh,
Yes.
What did that answer that you guys didn't know already? Curious. And that was like, wow. Any light bulbs?
how to do it now.
I just feel like we see so many.
Yeah.
But I wasn't even aware of just how many pathologies there could be.
Yeah. I
Um,
don't think we've ever seen an abnormal.
Well, and then I just want to ask, because you put, for reasons of ordering it, you put atypical sacral dimple. Is there a typical sacral dimple that exists naturally, or do you know what I'm saying? Is there like a
There are
dimpling?
some like little, dimples. Seeing very shallow dimples that occur, but atypical maybe deeper. And
I think
also up above that, 2.5 centimeters above the anus. And if they're larger.
They know
I don't think they-
criteria of atypical.
And that just means they're more at a higher risk for actually something being going on
I
inside.
think they're ordering because they see the
But
butt
it's, so
crack.
if there's a dimple at all, that's
Okay.
how.
They order usually. If there's a dimple, they usually are ordering.
And that's not normal to have a dimple.
I see normal like little dimples, but
Right.
not everyone has them.
I think what they're seeing is they see the top of the butt crack and
Yes.
it's a dimple.
I feel like in the past that I have had a lot of that.
I think that's what ours are
Mhm.
seeing. They're not seeing anything else. They see the top of the butt crack
And
and think it's a dimple and
they go ahead and they order.
it's, yeah,
But if they didn't, we'd have 0.
yeah.
Or we'd have like 1 a year or something.
Yeah.
you know,
Right,
that
right,
would be
yeah. Mhm.
Legitimate, but
And a lot of these really bad ones, you know, with the open or any
Right.
of those.
I think
Clinton's maybe had one.
Yeah, usually
That
they're
was
finding
fine.
those in utero
That's-
and then they're
that was the
sending
question
them
I was
elsewhere. Yeah.
we had one recently and I was like, could this be something before we went and did it? But I thought to myself, is this not seen in utero? Because we're clearing the spine then, because presumably. So
Right.
it's like, I wondered what we would see differently versus if they've had prenatal care. You know, what would we, like, would it just be something we missed or would it?
Right, maybe. Or maybe, you know,
Or get them off
discoloration
theory.
or something like that. Yeah. That maybe might not be so obvious in there. Yeah, which is why I kind of harp, I don't know. You know, I've only worked around here, but you know, whenever I ask, I'm like, do they do long and trans through the whole spine? And sometimes I would get, no, they don't. But I feel like over the last couple of years, I've gotten more who do trans through in utero. And I feel like, yeah, that's important, you know, to catch some of those things or those posterior elements are open in the back.
Because
We
we
just
were
took our
told,
transfers away.
yes, we were told to take the transverse
First
spine out of our anatomy.
Like,
scan.
quite literally a month ago. But anyway,
Well, we can just have some shelf up. Like,
it's just like, it's like, we
Yeah.
thought we were doing the right thing and then we're like, well,
chat.
I would think so too. Why?
in the fem text, would they say unnecessary?
Yeah.
It was unnecessary?
Yeah.
We're just taking too many pictures. It's not necessary to do the transfers. There it. Right?
Yeah.
Okay. I mean, we took it away.
Right. I mean,
We
I
were
don't
trying to
know.
follow their protocol.
Right. Well, it makes sense. Yeah, that makes sense. And you'd think, yeah, that, I don't know, other than.
Yeah.
Than I do. I mean.
I can take that back and just
Yeah, we'll
ask
see.
Maybe it's because their doctor will out.
Yeah.
on it or something. Maybe there's something I'm missing. Yeah, it could be on the reason, so I'll just ask her about it.
Or maybe they want you to look, but not take, that don't make it
Sure.
either.
Light bulb moment with me, I think would be, because I haven't had any, I was vascular and I didn't have any formal training on this. I learned it on the job. And it's like, okay, that terminates there and that's there and I count this. Anyway, the movement, I always felt like there was a lot of movement going on and I'm like, the nerve roots, there's other things moving. Is everything supposed to be moving? So like, that was something that clarified me. I'm like, okay, that is supposed to be moving.
Yes.
moving. And I've noticed babies before, some were not. It was like hard to tell if they were moving. I'm like, I think they're, and then some are super obvious. So that's something I learned. It could be due to prematurity because we do scan preemies.
Yeah,
We do spines. We've done that before. Or just like more
Dehydration.
early dehydration. Like
Yeah.
that was good to know because I felt like, okay, is it me or am I like,
why am I not seeing this? 'Cause
Yeah,
I've done that too.
but that could be like.
You don't
very
see it as
easy
much as you do on
information.
others.
Yeah, that made me feel better.
And I didn't know that about the dehydration. Actually. I started looking into reading all of this stuff, so I thought, oh, well, that makes sense. But yeah,
You can have you can have no coccyx and it still be in. Is that right? You can have no coccyx, you can have one, or you can have two.
I mean, like if it didn't form at all or ossified. So,
Yeah, I guess, I mean, if it's early on, would we just not, is it possible? Because it was
Yes.
a mother baby, right? And we
Yes.
didn't see the coccyx. And so
like
they were,
these, the ossified one is flat, it's S5. And
Yeah.
then those hypoechoic ones, they're just not ossified yet. That's 3 coccyx elements.
So that dark area,
Yeah, the
like
3
the scallop,
little,
like at the
mhm,
top.
the 3 little bumps, I guess. That's very technical. Here, here, and
Okay.
here. And then this is the tract to a dimple. But yeah, we've got some ossification centers, but it's not
Okay.
ossified yet. But, and that sacrament's pretty flat, so that's most likely S5. So yeah, earlier on, your newer babies may not have,
We may not
the
see it.
coccyx. Uh-huh. But then later, I know I'm going the wrong way, but anyway, there was one that was very round. So if you got an older baby and an ossified coccyx, it's normally gonna be more round than the S5.
I feel like I normally see,
There's the hypoechoic coccyx
yeah.
there. You can have agenesis of the coccyx and maybe associated with other things,
How
but
many is,
3.
okay. I didn't know that. Like I see two.
I've seen one, maybe 2, I think.
And we are doing it mostly early on, I
Yeah,
would say.
yeah.
I would say a majority of ours are within 24 hours, within 1 to 3 days of birth.
Yeah.
I would say. So we're gonna see
There's
maybe
probably
none to
variation.
1, 2. Right. I just didn't know what normal was, because that's what I was taught to count that way. So that I'm like, okay, there's not. But now I know other ways to count, so that's good too.
Yes.
So your
And that's always good too, because
is your
Yeah,
S5 gonna be
12.
more rounded than the,
that one, I always look at that and I'm like, I don't think that's right.
What is that?
This one at the bottom,
Yeah.
it looks like.
to me,
they
that
have
looks like that would
S5
be
label.
toxic.
It looks more like.
Oh, okay, I
coccyx
thought
to
that
me.
too, and I thought, well,
Yeah,
what do I know?
yeah, I don't know, yeah, I probably shouldn't put that on there, but,
It's good for the rest of it though.
Yeah.
I mean, you can see the conus and all that.
yeah. This one's a little more round,
So when,
and that's probably an older baby, we've got a lot of
yeah,
shadowing from those.
yeah. With transverse scanning, I feel like we have like such a array in which we label, like some people will do a cine through a couple, some people do like, do you know what I mean? Like S5 to S4, S4 to S3, it's like, is that probably the, like, what's?
I would say that's just however
Like if you
everybody
label.
wants to do, keep it consistent. If there's a radiologist preference,
They won't
keep it
even.
consistent. Okay, so,
Need help.
yeah,
only is what
yeah,
help
I think
what their
either-
preference should be.
either way, whatever you guys feel more comfortable with,
Okay,
or static images.
I find
Label if
that-
you can, whichever,
Transfer's hard.
to keep track of
To
where
keep
you're
track
at.
of where I'm at.
yes,
Always found that hard too.
And sometimes I will do a cine from the bottom up.
That way they could maybe.
That way they
yeah.
can see it.
Mhm.
They can go through it
yeah, that's what I
themselves.
was saying.
That's a good
we've
idea.
Been like in the city.
Yeah.
Yeah.
Like. Bills, 'cause I feel like you could.
And I feel
But
like they
if I
can
choose
always
to see-
stop it and start it on
That's
their
true.
things too, and they can evaluate. They probably got mad at me, but I did a lot of. They're like, oh my, this gal's got 5,000, not that many, but because I had clips a lot of times because I'm like, well, if you don't see it sometimes in real time, you don't know, well, what the heck is this, So sometimes I would do that. But anyway, no one yelled at me. Well, hopefully. That was what you needed. That was the question.
At start of two, not past anywhere
For the
past it
conus
is 3.
is, yes, it's
Okay.
between L2 and L3, right?
I feel like I've
The
had
conus.
one that I'm like, I can't, it's like a millimeter.
So the conus stops usually between L2 and L.
It should not go
At
any
or before.
further than the disk space of L2.
The disc space. I think that's what I
Okay.
need shown. What's, you know what I mean? I'm thinking like the start of the bone or the end of the bone. I think I know, but then that one that was really close to comfort, I was like, okay, wait, so yeah, that one showed it. So,
Yeah, that one's kind of hard too.
Let's see.
But, so if you're counting this space, it shouldn't be any lower than this. This disk space should
Okay.
be above that.
Okay, so
Disk
in my
space.
brain, it's like the end of this. It can be there, but it can't be past the end of L2's disc. Okay.
Yes.
Okay,
And then those preemies sometimes be a little bit lower.
it might shift.
It might, be a little bit lower, yeah.
Yes.
For both L2 and L3 disk space.
Except for me.
Right. Depends.
Yeah. Just gotta make sure I don't have one. Do I?
Well, I mean, I think we're done. So is she gonna record the next one?
It's still going.
Amy, press the button.
Still going.
Press the button.
Smooth the mic. Oh, there you go. Bottom right, bottom right.